To the second section of our NHS West Yorkshire Integrated Care Board meeting today here in Batley. We are now on item 7 of our agenda, which is my chair's report. As colleagues around the table know, this is about recording the work that we're doing together as a board in terms of board development sessions, work we're doing more broadly across our partnership in working particularly with the Combined Authority and the Metro Mayor, and also elements of our work together as boards. And it's particularly board appraisal time as shared in the report, which will be taken to our ICB Remuneration and Nominations Committee into the autumn. Just a couple of points I wanted to share for you around the table, as well as to put into the minutes. We have Anne Carroll, who is our Place Committee Chair for Wakefield, is staying on with us for a good few months, which I'm really pleased about and grateful for, in joining our and continuing to be part of our strong group of Place Committee Chairs in our 5 places. I also wanted to highlight that in working with colleagues, including Karen Coleman in our communications team, that we have had an average of 250 views of our board meetings in public every 2 months or so, and that is one of the highest in the north, and I think the highest in Yorkshire. So have a look at those on the viewing figures. I know there are a number of colleagues within NHS West Yorkshire ICB and also more broadly across our partnership who check in and view our meetings to keep up to date on decision making and information, but I do know that there are people outside of West Yorkshire also taking an interest in our work, so I'm pleased to hear about that. And something else in referencing our work with West Yorkshire Combined Authority, we supported the launch of the Combined Authority's West Yorkshire Plan, which I'm pleased to see had a lot around healthy places, and we'll be working with our colleagues over at West Yorkshire Combined Authority, including through the joint roles that Fatima Khan-Shah has and Jennifer Connolly has as well, in furthering that work together, which will link to the September Partnership Board meeting, which will be taking place in person, where we'll be signing a memorandum of understanding between the Health and Care Partnership and the Combined Authority and the Metro Mayor, which will be a great milestone for us. So that's a brief update from me. I don't know if anyone has any questions at all, but as I said, hopefully it's a helpful record of what we've been up to as a board and with leaders in the partnership. No questions. I'll take silence as satisfaction. That's great. Thank you very much. So we'll now move on to item 8, our Chief Exec's report. So Rob, over to you to share some highlights.
Thanks, Chair. So thanks to Ian Holmes for drafting the report this month in my absence. It's really helpful to him and the team to have done that for us. So I'll take the report as read. It's worth starting, I guess, given where we are with industrial action. And I just wanted to say thank you on behalf of the board to all of our partners and all of the staff involved in managing the consequences of the industrial action that's taken place this week and over the previous weekend. As ever, we've had very strong arrangements around managing the impact of the industrial action on planned care particularly, with our EPRR teams working very closely with each of the organisations, and within the organisations, the consultant body working closely with the management and management working closely with staff side to ensure that safe services are retained and as much activity continues as possible. Thanks also to communications colleagues who've ensured that the public are aware of what's available and what isn't during this period. So we are still in the position of there being industrial action this week. This is the final day of the junior doctors' action before the consultants take industrial action for the remainder of the week. This sustained period of industrial action does have consequences for services. And I'm very mindful of the fact it continues to have consequences for staff in terms of having to take the decision to take industrial action, and also to staff having to postpone or rearrange planned care for the public, which again can be emotionally draining and tasks which are not the ones they want to be delivering really. At this point in time, we know that the mandate for industrial action from the Royal College of Nursing has not been reapproved, so there'll be no further industrial action by the Royal College of Nursing unless they got to ballot again. We expect that there'll be some further noise in the system. Since this report was written, the Prime Minister has made it clear that the recommendations of the Doctors and Dentists Remuneration Body have suggested a 6% pay rise for DDRB groups, and that should be implemented, but that's the final offer and there'll be no more conversations or discussions with the union. So that is the government's best alternative to a negotiated agreement, they believe, and we'll see what happens next. But I really wanted to reinforce my thanks to everybody who's been involved in ensuring that the consequences of the dispute are being managed safely. We have now had several months of industrial action, and there are consequences which will continue into the medium term. I should also make the board aware that we as a board did a review of winter in March and what further action we might want to take coming into the next winter. The National Urgent Emergency Care team have required us to do some work now over the next fortnight by the 28th of July, self-assessing the system's preparedness for winter against a range of best practice areas, which will form the basis of the support offer that we get going into the winter. So there's a big piece of work going on in all of our places over the coming fortnight to make sure that we have a place-based self-assessment and then a West Yorkshire self-assessment of what we might require in terms of support going into winter. I think that's a recognition of the fact that there is good practice around that we need to adopt and share. There is variation in our places, we're aware of that, and there's more that we can do. It's also a reflection of the concern, I think, that there is ahead of the winter around the consequences of any spike in COVID, the flu season, any unexpected diseases or infections, such as we saw last year with Strep A, and the impact that had on children, on services as we go into the winter this year. We will be as prepared as we can be, and we'll be ensuring that we deliver as much care as possible and that we continue to improve services. But just to make the board aware that those processes are going ahead at this point. We also continue to make progress on our operating model conversations. Board members will be reminded that we have to make a 30% reduction in our running cost allowance. And we are doing that in one go rather than across 2 years because we have to pay for any redundancy costs out of our existing resources. And in doing that, we want to make sure that we take a full look at the way in which we are delivering our model of being an integrated care board so that our places, our provider collaboratives and our system are fulfilling and implementing the functions that they need to deliver our strategy. And we'll have our joint forward plan on the agenda later, which forms part of our considerations there. So at this point in the process, we've done initial engagements with staff around what functions should be consolidated at West Yorkshire, and then maybe support places or provider collaboratives. What should be done as a hybrid and what should be delegated to places or provider collaboratives. That engagement is now being tested, and then there'll be further developments in July and August with staff to co-produce the detailed structures that we will have in our new operating model. Because you can't take 30% out of something and have the same thing, unfortunately. It does give us an opportunity for us to get rid of some of the duplication that we know that there is in the system, and to streamline things and to take up the opportunities that we just discussed earlier on things like provider collaboration. One of the things that we'll need to do in all of that is make sure that every member of staff has got a job description which is up to date, which is consistent, which is aligned with the new model, and which is fair when it comes to pay and reward. So when we talk about headlines around things like running cost allowance reductions, we should be mindful of the huge amount of work that goes into that, and everybody around this table is involved in one way or another in making sure that we do that work well. Each week I chair a programme board which considers where we are in the process, the decisions that we need to take, and whether we're on track or not in what is an incredibly ambitious timetable. So by September the 26th, we will be going out to consult with staff on the recommendations that we're making on the future operating model. So the board should be aware of that because it's important, and it also takes capacity and resource from what we need to do as an organisation, and we should be mindful of that when you're making decisions about what we can achieve in the next few months as we go through that process. Also mindful that NHS England colleagues are going through substantial change. We welcomed the primary care teams into the Integrated Care Board on the 1st of July, so thank you to everybody who made that success, and caught up with some of them yesterday, and they were very pleased with the way that the transition had gone and the support they felt they had during that period. We continue to look at issues like dentistry, managing primary care complaints, etc. as we go forward. Colleagues such as Anthony and his team currently going through organisational change in NHS England, which itself is reducing in size, has a significant voluntary redundancy programme ongoing, and there will be knock-on consequences for the way that we work. So again, that's part of the work that we're doing together. Because we have a very strong relationship between the 4 ICBs and the region, and we meet every week, again, I'm confident that we'll do that in the right way, supporting staff and making sure that the functions get delivered appropriately. So as we sit here today, I think from the Chief Exec's report, the things I would reinforce are firstly, the big picture around NHS 75. Whatever you think about the NHS having a birthday or not, whether you think that's a great thing or a silly thing, how an institution can have a birthday, marking an occasion does allow people to express an opinion. There have been many opinions expressed about how we should fund health and care in this country, and there have been many expert opinions that says actually there's no model in the world that's got it right, and this model seems to be the most tax efficient way of delivering services and the best way of delivering services, which is universal. We have got things like the NHS 75 report that says, look, if at this point, as we come out of the pandemic, we've got an opportunity to think about where we shift. So shifting to prevention, shifting to personalisation, making sure primary and community services are well resourced and we have good and effective hospitals. All those things are in the ether. But we should really recognise that this is the context where people have used the NHS 75 to say some things about the way that the NHS needs to go going forward, and some have used it as an opportunity to challenge the model. And our staff will hear that constantly. So we need to keep reinforcing that, you know, we believe that integrated care, that working together, focusing on prevention, personalisation, primary and community services, good hospitals is the right way forward. I think the second thing I'd reinforce is, you know, finances are incredibly tight. The government have currently said that there'll be no additional resources to the Department for Health and Social Care for the DDRB recommendations. That will mean that those monies have to be found from departmental budgets. Whether that pressure gets passed to us or not, we don't know yet. That would be an additional pressure for us and additional efficiencies to find over and above the ones that we've got already. So the financial position is tight. Industrial action is difficult. We're in the middle of organisational change, and we're in a period actually where infectious diseases are at a very low level, and otherwise pressure in the system feels better than it has done for a long time. So it's a difficult period. We still continue to make significant progress on things like waiting, cancer, learning disabilities, with more to do. If you look at the balanced scorecard for a substantial number of those indicators, we're in the top decile, we're sort of 3 or 4 in the country, or we're in the top 10 out of 40, but some of them were not. So I think we need to keep focusing on what's good, focusing on what we can control and influence, and not worry so much about some of the other stuff that's going on. I hope that's helpful.
Thank you. Thank you, Rob, and particularly thank you for your role. I know you joined a national group in helping to bring that NHS at 75 report together, which has really endorsed a lot of our discussions already today. So appreciate you taking on that role and working with the Chief Exec of NHS England and others. Does anyone have any questions at all for Rob? Becky, then Maggie.
Rob, thank you. It was... we're seeing a lot about the strikes, and I see that in the dashboard now, it's featuring as a major risk for us across all our waiting times. It was good to see, Mel, in the AAA report from Bradford that you've named it about what the impact's been. So whilst we might be keeping people safe, we may or not, we're increasing their weight. We might wait them safely, but that has a cost on our third sector. So not only does it have a direct cost as we pay for consultants to cover for junior doctors, but it has a cost in our other services and it has a cost for patients. So, and I suppose I'm absolutely horrified that NHS England is not helping us with that cost, given that we had a budget set outside of those conditions. So I don't know what more we can do around asking NHS England to support us through this type of painful situation so that we don't end up passing that on to... I think saying we're going to find it through efficiencies, I would be surprised if we can find that through efficiencies. Can we?
So I think I need...
be honest about that.
Yeah, so I think it's... We've all been clear from the beginning, I think, that industrial action causes postponement and delay, which may lead to some degree of harm. So low levels or moderate levels of harm. That continues to be the case, doesn't it? But we continue to try and minimise the risks in the system. In terms of whether we're getting support from NHS England over the impact of the strikes, to be fair to NHS England, they've already changed the arrangements around the elective recovery fund requirements to mitigate on the degree of activity that's possible given the strike action. So that's what they can help with. I think it's a governmental treasury decision not to allocate additional resources to the Department for Health and Social Care. We don't know yet whether they will be able to pass any resources to NHS England to allocate to us for any additional costs that are incurred. So I think, to be fair to them, I'm sure they will be seeking some of that income on our behalf. But those decisions are not being taken by the Department or NHS England. I don't know if you want to say anything about that, Jonathan.
Yeah, thanks, Rob. I mean, I think it's a point really well made, Becky. We are still waiting to get the formal guidance through from NHS England, but there was a conversation led by Julian Kelly last week with all directors of finance across the country, and it was, as Rob described, that the latitude and the flexibility around how the elective recovery funding will operate this year was intended to give some support to ICSs, to ICBs, to trusts, to cover off those additional strike costs. I think we need to sort of see the detail about how that works through, because I'm not sure if it necessarily follows. So we'll continue to quantify and we'll continue to lobby.
Thank you, Becky. And we need to keep having this conversation, don't we, to work out what we can do ourselves and where we need to influence with others. Okay, thank you. Majid, then Fatima.
Yeah, just a quick question. There's absolutely right to thank the staff for the contributions that they are making through these really, really difficult times, particularly as we're also grappling with this restructure. I'm just thinking about well-being of the staff who are here at the moment, and I know we've got measures in place that people can access support and stuff, but if this is sustained and prolonged, is there anything else that we need to be thinking about considering to make sure that we do the best we can in terms of health and well-being for our staff?
What we've always tried to reinforce in the organisation is that it's your line manager and your team who are around you every day, who are the people who provide you with support. We shouldn't get to the point where people become ill, so they need help. We should be creating a compassionate culture where you are supported in your team. If you do need help, it's there, it's available, and you access it quickly. To help us understand whether we're delivering that and whether we've got the right kind of arrangements to support staff, there is a staff there's a staff group which is helping with the change, but there's also the staff networks who are helping us understand how it feels for staff members as we're going through the changes. But Kate, I don't know if you want to say anything else about what your team are doing in supporting the organisation.
No, thank you, and thank you for the point. It is raised understandably. Every month we have a full staff briefing for the ICB colleagues. Gosh, the last 3, I think there's been over 600 people attended those, which speaks volumes in terms of how important this is for everybody, and wellbeing does come up frequently. I think Rob's point is absolutely right. Part of, I think, the role of the internal HR team is to support line managers in their ability to support staff. So even this week, I'll be sharing with EMT colleagues tomorrow. Rob's mentioned earlier about the activity that needs to happen. Well, part of the role of my team is to give people support, guidance, advice as line managers so that they feel resilient enough and able to respond to those questions. We are exploring as well, Majid, in terms of locally having, experienced colleagues from the ICB able to act as, if I use the word champions, it gets overused, I think, but in terms of go-to people, all of us might have questions that we want to ask, which we don't necessarily feel we want to ask directly our line manager, or even perhaps sometimes the HR team. So there's all those sorts of local pieces that we're looking to really try and put in place over the next few weeks. But I think the other key thing is we constantly, remind all of our staff, right up to senior managers, of the support they can access, wellbeing support, anonymous support, very confidential. And this is a time when those services really do come into their own. So there's a range of sort of different actions that we are taking. Okay, thank you.
Great, thank you. And thanks to all senior colleagues and our comms team who are putting together those staff briefing sessions. And I know non-exec colleagues come along to support senior colleagues, as well as to hear firsthand about staff concerns as well as we go through this process. Thank you for that question. Fatima.
It segues on beautifully from the conversation that you've just had, because what we've done as staff network leaders and in the inclusivity champion role that I've got is have staff-wide engagement sessions. So what we've done in addition to the engagement that already exists is get all the staff notes together in a safe space to say what's on your mind, what are the areas that you're particularly concerned about that you need a safe space to explore that goes beyond just your management and your networks. And we've had some really, really great conversations that we're able to then channel through into some of the boards that Rob's referred to. I think the other thing that I wanted to say was, while we talk about strike action, the impact and the implication isn't solely those that work within our front-facing provider organisations. It also impacts the people that are behind the scenes, coordinating, facilitating and dealing with the aftermath. And we can't lose sight of them too. And I think quite often they're forgotten in these conversations. And I think the other thing we need to acknowledge and recognise is just that we can't let this become the norm. And I see a sort of a direction of travel that worries me, where people are expecting this to continue indefinitely, and then as a consequence this will become the new normal, and we can't let that happen. So going back to Rob's point about focusing on the hope and focusing on what we can control, I think we really need to proactively as leaders role model the behaviours and values that are important during this time, but also where we can mitigate this becoming the new normal, because it will have a significant impact on our patients and people.
Thank you, Fatima. That's really welcomed. Any other questions for Rob on his report? No? Anything you want to add, Rob?
No, I'd say just thanks to Ian and the team for pulling it together in my absence while I was on leave.
Okay. And to also note, since we last met, Airedale NHS have received new hospital programme funding for their RAC issue, and also Leeds Teaching Hospital Trust have also had their new hospital programme funding confirmed as well, which is incredibly welcomed around the priorities we have in our system at the moment. Okay. So we're going to move on now to our next item, item 9, which is our integrated performance dashboard. So first of all, thank you to those people who've been joining a few task and finish group meetings on Teams to talk this through, debate it. I love the passion that people have on getting the data right. I really very much appreciated that, as well as looking at the requirements for NHS England, but also what we want for our system, and also around understanding inequalities. And I think first of all, to connect back to our conversation on community services, we've already given ourselves an action on looking at community metrics to come with this, which is an important part of our development. So, Anthony, have you got any highlights? And again, thank you to you and Lou and others in the team for developing this.
Yes, thanks, Chair. And as you say, thanks to colleagues from around the table who've been doing a lot of work to develop the scope, the format and the content of this integrated performance report. So this is the first of, if you like, that new style of report that we'll be bringing back each meeting. So I think one thing we'd like to do today is to agree whether this is the approach we want to continue to take. So I'll just summarise what we have changed and what the proposal is to take us forward. I'll draw the board's attention just to 3 or 4 points of current performance, and then hand over to Jonathan, if I can, just to take us through the financial position. So in terms of what we've done through the Task and Finish group, we've kind of reorganised the dashboard to cover 4 categories of metrics. First of all, the metrics from the NHS outcomes framework, so the national must-dos. And then secondly, some measures from our own ICB joint forward plan, so making sure we're focusing on the strategic changes we've agreed to prioritise. And then more specifically within that, the 10 big ambitions. And then finally, finance and productivity metrics. So that's the sort of 4 core categories of performance we're proposing to look at. And each slide indicates which of those categories the metric relates to now. Today's pack is very big, I'm sure you've noticed. Part of the reason for that is it's got a lot of benchmarking data in. That won't be the case every meeting. What we're going to do is alternate one meeting with a lot of benchmarking data to show how we compare with the rest of the country. In alternate meetings, there'll be a bit more of a focus on the 10 big ambitions. So if you can bear with us, it'll alternate between quite a big pack and a very big pack. And we've also changed the format of the slide to include the commentary and added the commentary now in a more consistent format. So hopefully it's much clearer what we're looking at, what the reasons for variation from plan are, and what we're doing about it. And then finally, there's an opportunity for colleagues who've contributed to the commentary to highlight any areas of support or action that they're looking for. So that's how the report ends up in this shape. Just in terms of, as I say, drawing the board's attention to a couple of key areas of performance, and I'll refer to the pages in the meeting papers bundle, just if colleagues want to flip to the right slide. So just to start on slide 84, or page 84 in the bundle, this is the slide on A&E performance. Just to note that we're making good progress, I think, as a system towards the target for this year of achieving 76% 4-hour wait performance. We were at 72.8 in May, and in Q1 before that we were at 73%. So that's actually improved quite a lot since last year. So just to indicate that I think we're on track as things stand to get to where we need to for the year as a whole on A&E performance. On page 88, we've got the indicators on ambulance response times. Just wanted to note on category 2 performance, we were averaging 28 minutes 30 seconds in May, and that was almost a minute better than the target for May, which was 29.5 minutes. I just wanted to link this back to the discussion we've been having today around community services and the real importance as a system of contributing towards the improvements that YAS need to make by reducing demand for ambulance conveyances and for action by YAS through things like urgent community response and some of the other things we've been focusing on. So I think a real indication there of the difference hopefully we're starting to see happening as a result of the priority we're giving to those issues. And that'll continue to be a key focus for us as a system in working with our neighbours across Yorkshire and the Humber for for the rest of the year if YAS are going to stay within that Category 2 target. Moving on to elective care on slide 109, or page 109, just to note on 78-week waiters, we were expected to have eliminated 78-week waiters from April. We have been working to really get that number down as low as possible, recognising that we have seen the impact of the industrial action. We've also got some specialties, particularly complex spinal surgery, where it's very constrained, and Leeds Teaching Hospitals in particular is being supported to address the implications of that. So just to note, we're on track to actually get down to 0 78s by, I'll shout, shall I, by the end of the summer. So we've made further improvement from the position indicated in this report, and that will be reflected in future published data. And then the final indicator I just thought I would mention on page 131, this is on infection rates, in this case for C. difficile. And I just wanted to note that there has been an increase across the country and within the system. And so this is not unique to us. It is, I suppose, an area of concern across the country. So just to note that is an issue. All of our trusts are working carefully on that, and each has a strategy for managing infection. So I just wanted to note that that's something we'll keep a close eye on, and I'm sure we'll do that through the Quality Committee and Quality Forum as well. So I'll pause there, Chair, in terms of the metrics. Either take questions now or hand over to Jonathan for the financial performance, whichever you prefer.
I think we'll go to Jonathan, and for people in the room and anyone watching online as well, we're in a community venue in Batley today, and there is another part of the building being used by children and families at the moment, which you might be able to hear in the background. So, Anthony, thank you for carrying on with your report there, as there was noise going on in the background, but this is what we want to do. We want to be out and about in communities. So, Jonathan, would you just give the highlights of the finance report, and then we'll take some questions.
I will. Thank you, Chair. So I just wanted to briefly just cover off the month 2 financial position. So board members will recall that as an ICS, we've got a break-even plan for this year. That's comprised of a £25 million surplus in the ICB as a statutory organisation and a £25 million combined deficit across providers. So our year-to-date position at month 2 is that as an ICB, we were £5.2 million behind plan. That was driven primarily through the additional £25 million surplus that we agreed to as part of our financial planning for this year, for which we still require mitigations and measures to implement to resolve. We also had a combined year-to-date variance of £9 million across providers, 80% of which sat into organisations, LTHT and Mid-Yorkshire. Both of those providers, but all providers to an extent, were hit by a number of issues at month 2, some of which we've already discussed today. So the costs of the industrial action, the inflation costs that in some cases are above planned levels, a potential shortfall that we've seen on pay award funding for this year, and also some slippage on efficiency schemes. So those 2 year-to-date variances described, 5.2 in the ICB and 9 million in providers, means that we were behind a plan by 14 million at month 2. We had, given the status of our plan, been asked as an ICS to consider a range of expenditure controls as we submitted our plan, because we submitted a break-even plan, not a deficit plan, so we were encouraged to consider those controls. Because of our year-to-date position, we were deemed to be in one of the 15 systems across the country that were exhibiting more financial distress and risk at month 2. So that changed the advice or guidance from NHS England from being encouraged to look at those controls to being required to implement those controls. And we spent some time at the last Finance Investment and Performance Committee describing the measures that we will put in place to ensuring that we retained a proportionate response to those measures, but equally got the best impact and the maximum value out of them. So that really covers off our month 2 financial position. As an ICS, we continue to forecast as an ICS a £25 million adverse variance for the full year against our plan, in line with the conversation that we had at board last month, where we said we would require some time to identify those measures to close down that residual surplus. By exception, there's nothing I want to pull out in terms of agency spend or mental health investments, spend, both of which are in line with plan.
Thank you very much, and that's outlined fully in the report. Okay. We've got around 10 minutes or so for questions. So I think on the format of the report, feel free to send emails through, I think particularly through to Laura and Stacey in the governance team, as well as to Anthony and his team, if there's anything additional that you'd like, or some positive remarks, because I really love the format that we have. And just for the record, as you can see, we've benchmarking ourselves against all 42 systems in the country, including our colleagues in our region, and we have let our colleagues in the region know that this is what we're doing out of courtesy as well, and we hope you find that reporting helpful. So does anyone have any questions or comments? Melby, do you want to come in first? Thanks.
Yeah, thank you, Chair. Just conscious that on page 84 you didn't have the Mid-Yorkshire Teaching Trust position on A&E. So for May it was 73.3%, so we're not an outlier. And over the last 3 months we've been able to reduce our longer waits in A&E by about 4% as well. So I just wanted to give assurance to the board on that.
Great, thank you. We'll note that down. Becky, then to Rob.
A couple of specifics, Andy. One is that I really like this commentary alongside all good data should have commentary. It's really, really helpful. So it helps me ask this question, which is the summary mortality indicator. So the investigation leads failed to reveal any problems in care, even though we had, Rob, we found this, didn't we, at Quality Committee, or you did, at Quality Committee. So is that metric no use then? And do we need a different metric if the metric's not actually showing us anything, or was it a one-off and it was a bit of a flaw? So one thing about, is the metric or the measure, is that any help? Should we think about another way of measuring that? Second thing is children, young people, mental health, Anthony. Huge, nationally, this is something that's all over the press, all over our kids. We've been talking about it for a year now at the board. I really want some metrics around that, please. Thirdly, we're obviously still doing a bit of work, aren't we, on primary care? And it's good to see GP patient survey in. It's obviously just out again. It doesn't have commentary. Could we just please ask that we don't aggregate it around CCG particularly, or certainly not on its own, because it tends to be a few practices that skew it, and we really need to know those, and we need to wrap our arms around them and help them be brilliant for patients. So it's not necessarily very helpful to have an aggregate, because we often know where they are anyway. So let's have a look at them. It's a really great indicator of where there's good quality care. Thank you.
Okay, so thank you. I suppose the second part of your comments and questions around those metrics, so we can, during young people's metrics, we've requested also for community metrics and greater sophistication in the primary care metrics and reporting. Can I just check, are you asking about the first part of your question around the summary hospital mortality indicator, the SHIMI information on mortality?
Yeah, is it any good as a metric if it shows something?
Oh, we could have a whole hour's debate on that, maybe. Anthony, James.
Yeah, so I think it's a good ask. I think Becky, in terms of that, I think after the discussion we had at Quality Committee around this, I think the benefits of this is it enabled us, it highlighted something for us to go and ask. So I think it has its limitations, as you say there. Is there any other kind of marker out there that you would say, yep, that's the one we'd hang everything on? I think following those discussions, I went and had some discussions with some of our medical directors at our trusts, and talk through their understanding of it there and other indicators they're using. And I suppose there isn't one indicator that would sit here and go, that's the one we're going to go for. If this enables us to then ask the questions and be curious, and then go and for places to have those discussions, for organisations to have those discussions and have that curiosity there, then I think this is as good as we're going to get with it there. But what I wouldn't say is hang everything on this and go, right, look at Leeds, look at what's happening at Leeds. If it enables us to ask those questions and then find assurance, and actually, when I spoke to the medical directors in our trusts, the amount of detail they go into, and I'm sure colleagues around the table would confer in terms of understanding their mortality impacts, is quite astonishing, actually, from the discussions I've had, and also reassuring in terms of understanding, and it's actually there's a lot of learning we can take from that and spread it wider within places and across the system. So it enables us, the bottom line is, I think, I'm not going to sit here and say there's a better one to use. There are other ones, but I think we'll also have limitations with those. But if it enables us to then have a bit of curiosity to ask those questions, and then we go and we follow that through, then I think it's doing its job. But what I wouldn't want to sit here and go, oh, right, let's have a look at these, and they must be doing X, Y, Z. But if it enables us to have those conversations, and that's the way I would put it. I'm happy to take any.
James, thank you. I think Rob wants to come in, and I have a question as well in relation to it. Rob?
Yeah, so I think when we first discussed this, I think I reminded myself of what the guidance says when you look at the standard hospital mortality index, or SHIMI, and it does say, but this isn't verbatim, but it says something like, does levels outside this this measure may prompt cause for concern, something like that. So there may be a possibility of concern. So roughly sort of plus 10 percentage points. So if you get to 110, it's starting to look a bit, you should be asking some questions. So the Leeds data, for example, if you look at the individual hospitals within Leeds, they don't trigger you should be asking some questions. Or when you amalgamate it, it's just about, it's on the borderline, but you should still be asking the questions. I think you sort of start to say, well, that's interesting. Let's have a look. But what it doesn't say is there's a problem here. Now, I think as a board, because you've got a set of measures which say, look, have a look at this, we should be seeking assurance that somebody's had a look at it and that they have had a proper look at it and they haven't gone for an optimistic perspective, but they're really looking at some of the other indicators and saying, is there a problem here or not? And then through the quality committee or through the arrangement, should be saying, well, we're assured actually that people are doing the right thing. They've seen the indicator and they've said, oh, well, that says have a look. They've had a look. There aren't concerns. But that's the way it should be, I think, Becky. It's not that it's useless. It's a trigger. It's kind of a gateway indicator into, is there a problem here? What that means, I think, for what we've got in front of us, I think we should be putting on this chart particularly what that guidance says about, what would trigger your interest. I also think that it may not be useful to have an amalgamated indicator at West Yorkshire level because it flattens too much out. Whereas if you looked at, there is a differential between the different hospitals. And whilst I've got the microphone on the indicators themselves, I think there's also a kind of double jeopardy issue for GPs on this. Because I think on the indicators in front of us, so for GP appointments face-to-face, we do really well. And it says, a low score is good. And then for telephone appointments, we do really badly, and it says a low score is really good. You can't have both. So we need to be internally consistent here. Which one are we trying to promote and why? Because we've got to be measuring the things that matter to us. But I think we should be congratulated. I think primary care generally looks positive from the indicators that we've got in front of us, which is to their credit.
Thank you. I just want to take Chair's privilege, just going back on the SHIMI, the Summary Hospital Mortality Indicator, and it's a broader point on how we're assured that all our trusts, and I'd say community mental health and acute, are undertaking good practice around learning from deaths. And it was particularly, Becky and I went along to Bradford District Care Trust a couple of weeks ago, and it was actually around children and young people's mental health. That was our focus that day. I happened to talk to the medical director that day who said, do you know what, we've been doing some good work on learning from deaths around learning disabilities and mental health. And I just wonder if is that something perhaps the Quality Committee has looked at? How do you feel, James, that we're doing in terms of practice there and medical directors making sure that this is good practice and positive learning, celebrating good things as well as learning from things that perhaps haven't gone so well?
So I think there's a lot of work going on in our places and in our organisations that look at that. I think the arrangements we now have with across our places and the arrangements we have across West Yorkshire, I think there's greater opportunity to learn even more and share even more of that. So actually, it is timely. So the medical examiner role is also coming. It has also coming in across primary care and the community to be initiated in legislation by next April now, end of March of 24. Medical examiner role has been in secondary care for several years now. So at the moment there is a group bringing together the medical examiner across our places to kind of look at, first of all, are we learning in terms of the process, because it's a new process, but actually there's so much more to then just understanding and sharing what the process is. It's about actually the shared learning of what's going across primary care, communities, how that links in with secondary care. So I think there's far more to do, and I think there's, but I am encouraged with what's going on, and that timely, both in terms of the medical examiner's role, but also in terms of our arrangements through Quality Committee as well, in terms of how we bring together the work that goes across already at that moment through Wyatt, through our trusts, through our other organisations, and now with the medical examiner, how we bring that in as well. So more work to be done, but there's work happening as well.
Okay, thank you. And I think that's something that maybe Quality Committee want to look at, and also to recognise within NHS Trust there is a non-exec remit for learning from deaths, as well as maternity safety champion. Those are the two really specific ones. So I think that's something as non-exec colleagues you might want to look in as well. It's something I always take an interest in as well. Thank you. Penny, did you want to come in? And then we will go to Fatima and then Harris.
We on? Yeah, thanks. Sorry, I can't take the nurse director hat off, and I know I'm sat here with the place lead responsibility today, but I think it's just following up from what James is saying and just giving a flavour of a conversation that happened in Kirklees Place in the Place Quality Subcommittee a couple of months ago. So it was moving from a single organisational lens around learning from death, so understanding the focus had been sat largely in acute, but then taking a view about what was happening in our community services in Locala, with the mental health services in South West Yorkshire Partnership Trust, and also that rollout of the medical examiner. So we took a learning paper into the quality subcommittee and thought about the opportunities in there. Now what I understand is my colleague that authored that paper on behalf of the partners is now linking with a colleague in James's team around, well, what did we do in that paper? Where were we going? And now how can we take that learning from a place in a structure into something that we can then look at across the piece. So I think it was just a useful look at in terms of as the policies changed, we can do much more from a place into West Yorkshire.
Great, thank you, and exchange that good practice as well across other places. Thank you, Penny, that's really helpful. So we're going to go to Fatima and then Harris, and then we'll probably move on to the next item. Fatima.
So, Anthony, I love this report. I'm sure you're pleased to hear that. And the reason why I like it is because it gives a really great overview of the data, but you also explain to me things like what we're doing about variation, how do we compare to other places, what are the risks that I need to know, which as an ed in another life is always helpful to understand. Obviously, as a lady who's always striving for improvement, I do wonder whether there are more opportunities about the health inequalities and the learning that we've just discussed earlier from the what gets measured, gets done type of conversation. So when we discussed this as part of the briefing for Race Equality Network members, there were some suggestions that I'd really like to share with you. The other bit, if I may, is, as a woman that's got a memory like a sieve, is there an opportunity within the report to remind us of things that have happened in the past? Because as I sit in other boards, I then forget, and there's usually a journey or a trajectory that we need to be mindful of or cited on, and sometimes that gets lost in reports like this. So obviously, if we want the best one in the country, because this will be, there may be two things that would just take it to that next level.
Okay. Anthony's nodding. So I think we're saying that we don't want to fundamentally change this report. It's about finessing and tweaking it. I'd suggest over the next 9 months or so, and let's test it out. Okay, thank you. Harris.
Thank you. I echo everyone. It's an absolutely amazing report. I can understand it now. So just a question on the 12-hour A&E waits. For example, Leeds having a 6% of people waiting over 12 hours. That's quite a lot of people that are there waiting a long time. So what was the harm caused to patients because of waiting 12 hours? And when reviewing the 12-hour breaches, were there any common themes, and what work's happening across the system to reduce this? Is there any shared learning of areas where they have low 12-hour waits compared to areas with high 12-hour waits?
Thank you, Anthony.
Yeah, thanks. So this is on page 84, colleagues. Sorry, it's page 85, notes not 6, thank you. I just want to click to it. So this is the indicator on total time spent in A&E, and Harris is flagging up variation quite rightly. So we haven't done any work to actually link these waiting times directly to harm. I think that's something Trust will continue to look at routinely in terms of their own internal processes. I think the point around how can we help organisations learn from others that have got lower weights and that perhaps have better flow overall. I think that's something we can pick up with the urgent emergency care programme, just to see what action we have going on to support the system with that, and whether there's more to do.
Thank you, James.
Yeah, thanks. So just following on from Anthony's comments there, in terms of what we learning and how we can support. So I think Anthony's the urgent emergency care programme is chaired by Claire Smith, who's the Chief Operating Officer at Leeds. And through that and through the UEC, the urgent emergency care aims, she's brought together very much like with the plan care, she's brought together the COOs to look at some learning in terms of for urgent emergency care across the trusts there. So I think it's already started in terms of the approach of making sure actually as a system we're working together, both in terms of reacting quickly, but also in terms of what we're learning across the system and across our trusts there. So that's in place, and as Anthony says, be taken up through the urgent emergency care programme.
Okay. Thank you for those. Thank you for those responses. Rob, did you want to come in?
Yeah, so I think coming back to that normalising point, I think we're on an improvement trajectory. So as Anthony says, we're getting back towards the standards we'd want to see in terms of what we're being held to account for in terms of A&E at 76% and response times for ambulances getting towards 30 minutes, but they're not the constitutional standards. And these are stepping stones towards something which is better. So we've got to keep our eye on that as we get into the medium term. We've got to try and get back to the standards that we would clinically and legally be required to deliver, I think. So that's one point. Secondly, I think it's great to see the performance on cancer being so strong. I know that we'd prioritised cancer as an ICB and as a system throughout the pandemic. And you can see for most things we're in a pretty strong position comparatively. Again, we could be better in delivering the standards that we want to see, but comparatively doing pretty well. And I wanted to say thanks to the Cancer Alliance and to everybody who's been involved in that. I do think the point about IPC, we don't look good on IPC on any of the generally in terms of this benchmark. So I know that Bev is doing some work with the organisations on that, and we should put that on record because it stands out so much from this report. I know we've mentioned it to some extent, but it is something that I would want us to continue to focus on, and perhaps we'll get a report after the Quality Committee next time or through the arrangements. Bev might want to see us to say something. The only other point that stood out for me in terms of the report was IAPT, in terms of the deterioration of performance in Bradford District Care Trust. And we've had conversations about Leeds and its model in the past and whether there's a legitimate difference between the Leeds service and others, which means that recovery won't be 50%, it'll be nearer 40%, but the performance in Bradford has deteriorated substantially, but the performance in Swift's remained steady. So I didn't know, Sarah, if there's any particular work going on across the collaborative to look at IAPT and how we make sure that we're maintaining good performance on what is a high volume service which makes an evidence-based impact on the population.
Not specifically, Rob. So in terms of IAPT access and that whole aspect of mental health support, that's managed within place. In terms of the interrelationship with different partners, what we do is periodically say, is there anything different that we need to learn and share together? So we'll pick that up through the next meeting, see if there is anything specific that we can do at West Yorkshire footprint.
Okay. Thank you. And Sarah, also thank you for responding to a query that I had on behalf of some provider trust chairs on our working relationship with West Yorkshire Police going forward. I know that's something that you're looking at through your executive forum and through the provider collaborative as well. So thank you for that. Okay. I just want to, any questions on finances, or do we take Jonathan's report as read? And take that as read, but thank you very much, Jonathan, for that. And now we'll go on to the risk register. Laura, what would you like to highlight? Thank you.
Yeah, thank you. I'll do a fairly brief introduction, and of course the report is here to help inform the other discussions that we have on the agenda. So we've already mentioned a number of the risks in other discussions, such as the staff wellbeing. That's a new risk that's come on in respect of the operating model work. We've talked about RAC at Airedale, so you'll see that it does come through in the other discussions that we have. So the report's in its usual format. There are details of all of the risks that we have on our corporate risk register, and we also have detail of those high-level risks that are on the place risk registers, and where we've identified common risks that occur in 2 or more of our places. The areas I probably want to draw your attention to are our new risks that are set out at paragraph 3.4. We do have some really high-level ones that have come on this cycle. We've got 2 that are critical, and we have 3 that have come on at a serious level, so I'd just draw your attention to those. There is a short summary for each of those in the main paper, and then the full detail is within the appendix, and it also flags for you which committee has looked at those risks as they've been working their way through the risk cycle. You've also got detail of all of our high-level risks in there. We currently have 6 that are rated as critical, and a further 6 that are rated as serious. And our risk on a page report, which is one of the appendices, gives you a useful overview of trend data that we build over a number of risk cycles, which is an overall fairly stable picture, albeit there are a large number of static risks, and static risks are those that have not changed score over a number of cycles. It's not necessarily of concern, but sometimes it can indicate that further attention needs to be given to certain risks. Following feedback from the Audit Committee Chair, just want to flag for you that we have a new addition to the place risks appendix this time. So we've always shared with you the 15 plus place risks. The Audit Committee Chair suggested that we also include the target score, so you get an idea of what our level of tolerance would be for some of those risks. So hopefully you'll find that helpful. And you've also got a summary within the report of the feedback we've had as we've worked our way through Executive Management Team and through Finance Committee and Quality Committee. The final point I just wanted to make was just to flag that as we go into the new risk cycle from tomorrow, our intention is to focus on those risks that have a likelihood score of 5, which means that they're almost certain. We feel that a number of those have actually become issues rather than risks, so we are going to have a real focus on those during this next cycle, so I expect you will see some changes as we get into the next meeting. Thank you.
Okay. Thank you very much. And we also note on the financial delivery, our aim is to, and requirement to achieve a break-even budget in 23-24, but we have just received the report there from Jonathan. We'll have ongoing oversight and insight on that, particularly at this time. Okay, are there any questions at all around the risk register? Sorry, Becky.
Yes, just to note that children and young people's mental health finally appears on the risk register and comes in at a stonking 20 plus. So it's good to have it here at last, but it's a real concern. And I think whilst we're moving to a collaborative ICB event with our colleagues and partners, there's been some really interesting and amazing work done at place. I don't think, and we will hear about that, I'm sure, in September. But it's also a real struggle. So we had a fantastic visit to Bradford. Kathy, that really, really interesting, but also really shocking. So whilst there are sort of 1,000 things they're trying to do to try and keep people safe, the reality is the CAMS caseload has doubled with no extra staff, doubled from nearly 3,000 to 6,000. That's a big double, isn't it? That is absolutely huge with no extra staff. And absolutely not appearing back to our database, not appearing on any waiting list initiatives. Absolutely understand Mel, it's for place to determine how to support and fund its own allocations, but I do think we need a conversation about this still. Feels to me like that crisis has emerged, has stuck, it's not going away, and I'm still unsure about our overall approach to this as a matter of urgency. It feels to me like it's a crisis. It feels those families we saw last September, it's a crisis. So if we've got our strategy on the table here, which is we're going to reduce life expectancy by 10% for people with mental health. Not like this, we're not. So I'm really concerned about it. I'm glad it's here at last. It seems to be taking a bit of time, and I don't understand that, and I absolutely applaud and know the solutions have to be determined locally, but we also need to find out which of those are working best, and we need to find out quickly, and we need to have a solution for CAMS.
Thank you very much, Becky. And just for the record, Becky and I, as I said, visited Bradford District Care. They hosted a roundtable discussion for us. It was nearly a full day in meeting people across different sectors and different services on how they were working together in schools, across NHS and voluntary sector services. And there were some brilliant examples as well, but their main challenge, as they shared with us, and their opportunity is then to mainstream that, which was something that's being pushed through their place committee and their health and wellbeing board at the moment. So, Richard, did you want to come back in and respond to that? And I don't know if Sarah or Rob want to come back on that as well. Thank you.
Yes, it's on a related subject. I mean, the second of our big risk ratings is the risk that neurodivergent population of West Yorkshire don't get appropriate diagnosis, and we've mentioned that previously. It's something that's been highlighted nationally as well, sort of in the last few days, around particularly ADHD services, both for children and adults. We know it's a big issue in West Yorkshire. I think one of the things that we should consider is what advice that we give to referrers. There is little point GP practices referring into a service that's already at maximum capacity. And I think we need to actually be honest with the population. We need to give appropriate advice to referrers so they don't just add more to a waiting list that is not going to actually enable patients to get the appropriate service. So we need to find a way to actually support our patients appropriately and support our referrers. Yeah.
Thank you, Richard. So, Sarah, I don't know if you want to come back first and then Rob.
Yeah, I'll work backwards. So we had a good discussion at the System Oversight and Assurance Group on neurodiversity on the back of the deep dive, and which was a really helpful place to have the discussion because it was all different sectors involved. And what we agreed on the back of that is whilst there's a set of actions we are taking and we're on with, it does require something radical. Does everybody need referring to a specialist service for a diagnosis? Does everybody need to sit in a specialist service to access medication for the rest of their lives? What other adjustments can you make in the lives around people with neurodiversity to prevent them having disabilities in effect or disadvantaged? So there's a summit. We've now got a date in the diary. What we agreed on the back of that is in addition to the work that we're doing, we're going to hold a summit and invite some key national and local people, which I think we've now got confirmed in your diary, Rob. We were just waiting for you to get back from leave. So we'll cover some of that when we come in September. But whilst we've not got a plan that's going to solve it all, the plan is beyond what's within our remit to be able to solve. And again, coming back to children and young people, we will include that in the September session, but probably not to the extent in which we could just do one topic on children and young people. And again, the bit we need to hold in mind, what can we do differently broadly that doesn't mean that there's 6,000 people needing to be on a caseload in Bradford to access specialist mental health services? None of us wants that. And we had a discussion because this year's public health report for Leeds, in my shoes, was all around the experience of COVID on children and young people, and some really startling statistics, again, in terms of deprivation, breakdown by ethnic groups, where people live in the city, of where there's more adversity, as well as some positives. So to some extent, how do we see through that and respond differently? Because the causes of people accessing services is very different than what it was 5 years ago. So we need to not over-medicalise our response to children in distress needing support as well.
Thank you. And this is what this board is here to do as well, is help you if you need to make some radical changes or make bold decisions. And we do it very in an informed, evidence-based way. Rob, do you want to come in and then Mel P?
Thank you. I just wanted to reinforce what Sarah was saying. I think it's well understood, the CAMS problem, particularly in Bradford. But it reminds me of where we were with urgent emergency care for physical presentations a number of years ago, where the only place you could go was A&E. So we've got to create alternatives to that one entry point.
and that understand, well, we have to create them, and then we have to share that they exist and that they can be effective, and grow the confidence in them. So that's the job of work. I had a conversation with some senior leaders in our place, actually, and someone said, you know, if a child is absent from school for 48% of the time, they clearly need a CAMHS referral. And that's the kind of level of expectation around what CAMHS is actually there for. You know, and I said, not at all. We need to understand why that child isn't there. Maybe they have caring responsibilities, maybe, you know, they have transport issues, maybe they have money issues. That there's all sorts of reasons. We can't jump to that conclusion. And I think that has fueled the numbers who are now waiting, and we have to work through those people who are on that with an expectation that they're going to go through a process, get a diagnosis, and really what we need to do is work with schools on psychological offers, work with the voluntary sector, work with buddies, work with our children and young people, our Healthy Minds apprentices. There are any number of areas we need to work with. CAMHS is not the answer, and we're making it a bigger problem than it needs to be.
Great, thank you, Mel. That's very much what came through in our visit as well a couple of weeks ago as well. Rob, do you want to come back in? I'm going to move us on to the next item.
Yeah, I think Mel said it really. I think there's a huge amount of work going on, and we've got to be part of the solution, not part of the problem. And I think if you think about the history of CAMHS in the last decade or so, it suffered from the atomisation of commissioning of CAMHS and the provision of CAMHS. So you had different tiers paid for by different people, and therefore, as services came under pressure, there was a kind of escalation. So people were inappropriately referred to the wrong service because someone else was paying. It's kind of happened over time, which meant that CAMHS didn't work very well. And over the last few years, we've really sorted that out by having a joined up set of services in each place in CAMHS to try and make sure that people get an offer and then connecting that to their bed base. In the meantime, though, what's happened is, you know, serious pressure in schools around their budgets and a serious increase in the morbidity, as Becky says, around genuine mental illness, which has brought on another problem, which is, well, the only place you can get some support is to make it a mental health issue. So school absence is a mental health issue. It's not. So we've got to try and get back to what is the problem we're trying to sort out here, and how do we make sure that there's an offer in a constrained context. What do we do in our children's programme? What do we do in our mental health programme? And how do we make sure that the medical offer is for medical need? So that we're not medicalising real life, and we're not putting resources in the wrong place. We should also recognise that organisations like Sarah's and others do have resources to recruit people. It's recruiting them that's the problem. And it comes back to the point earlier around community services and mental health services. How are we prioritising those roles for the future? So we have more health and wellbeing facilitators in schools. We have more CAMHS workers. How are we making sure that's a big part of our workforce strategy? Well, we are. So I think you're right, Becky. Let's make sure it's always on the risk register. It's always in the performance report. It's definitely in the performance reports for the organisations that are delivering those services. Yep. We've got the data. We know what the issues are. We should be collectively trying to resolve it. So let's be really challenging in September when this comes back. I think that we're doing all the right things, but we've got to make sure that all parts of the system are playing their role.
Okay, thank you very much for that discussion. I think that comes back on removing commissioning boundaries to enable support for the person, not based on history, that we had a discussion about earlier today. Okay, I'm going to try and help us catch up some time now. We've got moving on now to item 10, which are committee AAA reports. Now, what we should have aimed to do is in the previous reporting have covered a number of items here in terms of our ICB committees, audit, finance, quality, remuneration and nominations, which we'll talk about later, and across our places as well. I know, Bev, you're going to give us an update on one element linked to quality committee. So if you could do that, please. And then If any colleagues around the table want to provide anything else or highlight anything, please let me know in terms of the AAA reports. Bev.
Thanks, Chair. So I'm just trying to scroll down, but anyway, this is in relation to the Tong Park issue. Where are we? Sorry, I'm just scrolling down to the right page. I've got it now. So if you look at the AAA report from the Quality Committee, and the last point on the advise is an update was discussed and reviewed from lessons learned from the dispersal of asylum seekers in Bradford. So many of the board, if not all of the board, are aware of an incident that occurred in November of last year, where a large number of people seeking asylum were transferred unannounced. It was an unannounced transfer from the Manston Centre in Dover to a hotel in Bradford. We found out as an incidental where someone from Mears escalated to NHSE, and that came to ourselves on a Friday afternoon. There was no one in place or the system that knew about this unannounced transfer. Because of the, I think it was because of the collaborative working, it were escalated incredibly quickly. We set up a response cell to address it, and then very quickly, following some of the discussions and some of the risks that were posed as a result of some of these people that were seeking asylum and the ill health that some of them were experiencing, we decided to declare a system serious incident. So that serious incident has since completed. A presentation on learning and next steps came to System Quality Group a couple of months ago. The detail came to Quality Committee last month. This has been escalated. It were escalated at the time outside of the system, both to NHSE at national level, and we linked with the Home Office as well. So we've linked with other agencies, and we've set up a meeting to discuss next steps, learning and sharing from this incident. Thanks, Chair.
Thank you very much. That's a really helpful update, and we'll note that in the minutes as well. Colleagues around the table, is there anything else on the AAA reports? First of all, anyone providing the report on behalf of their committee, is there anything you want to highlight as urgent or as a priority around the table? Rob.
Just a general point, I think just to pick up the point that Laura made earlier around risks becoming issues that we just deal with because they've materialised. Maybe that's something we could ask the committees to do so that the risks can be closed off and they become issues that then get dealt with and assured through the actions of the executive.
That's really pragmatic, thank you. Any questions at all on the AAA reports? No? Colleagues who prepare them, they are incredibly helpful, really welcome summary. And there's also to note that all place committees have oversight and insight into the financial system finances for their place. We've also Leeds working as a Marmot city in Wakefield, Mid Yorkshire, has become has gained teaching trust status, which we congratulate them on as well. So there's some positive stories there as well that we can have a look through. Okay, so thank you to anyone who worked on those reports. They continue to be really helpful to us. Okay, we're going to move on to item 11 now, which is around our joint forward plan, which you have there. And as I shared right at the start of the meeting, this is something we're aiming to share in the public domain by the end of this week. So Esther, would you just give us an overview, please?
Yeah, thank you, Chair. So just as a reminder, you saw an early draft in May this year. This is a statutory duty of ICBs to demonstrate delivery of the NHS elements of the 5-year strategy, although in West Yorkshire we can't really separate out those NHS elements amongst other partners as well, so we've kept some of that together. You gave us some really helpful comments in May, something around the balance of the detail throughout the plan, the ambition versus reality, some work around the medium-term financial plan and a clear set of metrics, and hopefully you'll see that has been worked through into the copy that you've got in front of you today. There are a couple of areas we're just still working on. We're waiting for people who are coming back from leave, particularly around integrating some quality elements in there and also to strengthen up some of the EDI elements as well. well. Our places have been working really hard on the place plans that form part of this. It is kind of a bit of a Russian doll effect, and those place plans represent how they're going to deliver the 10 big ambitions, how they're going to deliver the delegated functions from the ICB, the long-term plan mandate, and also their local health and wellbeing priorities as well. They're all going through their local governance, but it's been a real pleasure to see that we've had some fantastic conversations across place leads, programme leads, provider colleagues, to make sure that everything knits together, and it's felt like it's been really different this time in how people have had those conversations, and a good bedrock for us to go forward on. In terms of the metrics, they'll be really helpful as we move into refreshing the plan, which won't be too far away from now. There's a little bit of a caveat. We need to do some work to understand which of those metrics are meaningful, timely and available in public, that can go in the public domain. So we will make sure we do some of that. It'll be linked through to the integrated dashboard that Anthony's highlighted today, so that we have a really good, strong set of measures to be able to determine how we're doing on the joint forward plan and link that through to the refresh. It'll also help us in being able to describe to Partnership Board where we are on delivering against the 10 big ambitions, because their forward plan will be linked to that as well. We do have to refresh this every year, and it seems crazy talking about that now as we're just signing off, but it links in with the operational planning timeline as well. That's not really detailed anywhere, but that's a decision we've made that this is the right thing to do. So operational planning later on this year will be year 2 of our joint forward plan. So we need to have those strong indicators so that we can have a sense check of where we are, and also to work with Karen and her team about making sure that we're using involvement to be able to check how people are feeling those services as well. We're trying to really pull together those different elements of planning, operational planning, the Better Care Fund and winter planning, which we're starting at the moment, to make sure they tell a total business planning cycle and we're able to articulate that. And then we're also able to set up ourselves to be able to deliver those strategies and plans as well. So this will inform through into the operating model. Just to say a thank you to all of the teams. They've worked really hard on this. We know we won't quite got it right this first time. We'll evolve, we'll keep working on this, but we think we've got to a really strong position at the moment. I've probably missed some things, but I'm conscious of time, so I'll take any questions. Thank you.
Great. Thank you very much, Esther, to you, Ian, and so many colleagues who've worked on this. And I think that principle around engaging, consulting, involving people in this plan has been really, really welcome. Thank you. And the metrics, the key metrics there, which I know they will then take to Partnership Board, which we've talked about for a while now, which I really, really welcome. Colleagues, do you have any questions at all? We're being asked to approve this before it goes out into the public domain. I know, Rob, you've got some amendments you've shared with Esther on the forward, having come back from leave on Monday. Fatima.
As Esther already alluded to, the EDI section in particular is currently being discussed and worked on. One of the things that has encouraged us to refocus on it is the publication, as Rob's alluded to in his report, of the EDI improvement plan, which has some specific metrics that we need to ensure we deliver as an ICB board, but also as an ICS. So I'm just flagging to the board that there may be some tweaks as a consequence of that lastminute.com. The other thing I wanted to sort of allude to was the how do we know we're making an impact bit, which I'm sorry, I've had to charge my tablets. I can't tell you what page it's on. We got some feedback from the Strategic Race Equality Network about the importance of the experience of staff. So there's a reference to a diverse leadership. There was some challenge from the network about what do we mean by that, because diverse can mean different things to different people. So do we want to specify what that means? And the EDI improvement plan will help us with that. And then the other part was ensuring that our staff experience is good. So the previous iteration of System 8 did specifically refer to staff experience, and there's an ask from the network to put that back in.
Thank you. So I know we've only got a matter of working days, but that's something that's being taken on board, as well as Rob's points as well. Is there anything else anyone wants to comment upon? No? Rob?
So yeah, thanks to the team for doing all the work on this. I think what it helpfully does is support us as we move to a business planning cycle. I think that's the step we should take really with this. So what we all know that the operational planning cycle this year was difficult, challenging, and didn't finish until partway through the financial year, which is never good. What we've now got is a 2-year plan which we can use for business planning, and I think we should be doing the business planning in advance of the national operational planning requirements, because our plan goes beyond the NHS England stuff. into things that we think are important, and we should try and use it, therefore, to do something this financial year that says, look, this is our plan for the future, this is where we're putting our resources, this is where the capacity is going. To support that, I think we could do with that helpful summary of what the key targets and indicators are, which says, look, this is what this really means for people. And I think we need to link it to long-term financial model work. So what we'll then have is, I think, a really helpful suite of things. We've got this year's plan and a set of a balanced scorecard which reflects that. We've got a 2-year joint forward plan which we can use for business planning. We've got a long-term financial model and a strategy. That feels like a good set of things to have.
Nods around the table as well. This is something, Jonathan, you have been talking through with us as well about having a longer-term planning around finances as well. Okay, thank you. So, Board, are we happy to approve that, subject to some changes? I just asked with those changes if board members could then receive the final copy before it goes out into the public domain out of courtesy. That would be really welcomed. Okay, thank you. Sometimes we approve things in a matter of minutes, Esther, and I know it's taken a long time to bring it together. So thank you so much to you and many other people. But Rob, I think that's real clarity as well on how we take this forward and make it useful for us. Okay, thank you. So we now move on to the committee annual reports, which you've got in item 12. I know, Majid, you're stepping in for Jane, our audit chair today, and Laura as well, if there's anything you want to share. But I don't know, Majid, are there any points you want to raise on this?
No, this is just part of its normal routine reporting of the audit committee to provide assurance that we've got effective governance arrangements in place. So what we have in place is a report from every committee. There's been a self-assessment done by each of the committees, and the assessment's gone back to the committee. They've had a look at areas where we've made progress, areas where we've got gaps, where we've got to improve, etc. And then that's reflected back into forward planning for the committees. So that's all there is in these reports. And Laura will be happy to take any questions if anybody's got any.
Again, thank you for all the work that's sat behind the scenes in doing this. It's great to see the learning that's been identified, by particularly in place committees, and then what is being taken forward in terms of practice as well as the work plans as well. So we've both got the reviews as well as the work plans that sit there broken down by each committee. Laura, is there anything else you want to add? No? Okay. Colleagues, are we happy to note that as well and receive the assurance on the plans going forward? Yeah. Okay. Rob, do you want to come in?
I was just going to thank all the committee members and Laura particularly for all the work that's gone into this. We should reflect that this is a bit of the work that takes up a lot of time, effort and energy and is critically important in our role as public servants. You know, we have to have good governance, be transparent and be open, and we have to do it well. And the fact that we've got, if you look at the annual report and the accounts and the statement of internal control, the significant assurance from internal external audit, we've done this well in our first year of operation. And the fact that we've got a report like this coming is an example of good governance. So I just wanted to say well done to the team for that. And we shouldn't let it pass without recognising the amount of work that's gone into it.
Thank you, Rob. That's great. It's we've had a great governance handbook, and here is the reality of it in practice as well, and the learning to take forward into 23-24. Thank you. Okay, so we'll move on now to item 13 on committee terms of reference and the work plans. Sorry, I've got myself confused here in talking about work plans before we got there. Item 13, Laura, do you want to just give us an overview?
Yeah, thank you. And the two fit together neatly. So as Majid said, all of the board's committees have been undertaking their end-of-year effectiveness self-assessments, which have helped to do the annual reports, but they've also been used to inform each committee's annual review of its terms of reference and also to inform the forthcoming year's work plan. So you'll remember at the last meeting, you had all of the terms of reference and work plans for the West Yorkshire committees. This time you've got the 5-place committee terms of reference and proposed work plans. The only one that you haven't yet seen is Transformation Committee, and we are still working on that in terms of the terms of reference and work plans, so that'll be at a future meeting. Thanks.
Okay, so and to complement this as well, I want to thank Laura for working with place leads and place committee chairs on reflecting on 12 months in on the role of the place committee chair, which is a new non-executive style role that we've got within our system. And I'm grateful to our 5 very enthusiastic and committed and highly professional place committee chairs that we have as well, and sharing the reality of their role so that can inform the ways of working going forward, which complements this. So board colleagues, we're being asked to approve those amendments to the terms of reference and the work plans for those 5 place committees. Are you happy to do that? Nods around the table, thank you very much. And again, huge amount of work, nodded through in a matter of minutes, but it's great, thank you. And again, as Rob said, really good governance. We now have item 14, which is our standing financial instructions, which we're being asked to approve. Jonathan, is there anything you want to share?
Thanks, Chair. So, excuse me. So this is the first annual review of the standing financial instructions. There are some minor changes that you can see highlighted through track changes in the document itself. In line with our scheme of delegation, it's been reviewed by the Finance, Investment and Thoughts Committee and is recommended to the board today for approval.
Okay, colleagues, do you have any questions at all, or can we go straight to approving the document? Oh, Rob.
Jonathan, I don't know if you wanted to comment on whether the SFIs need to be amended to reflect any of the additional restrictions being required by NHS England on spending.
I would say not. Primarily on the basis that the financial frameworks that NHS England may put in place for us may come in and then go, may be amended, aren't constituted in terms of statute or their constitution, and may change throughout the year. So I think what we are doing, though, is to ensure that all of the operational, almost like the operational scheme of delegation, if you like, that those are amended within both the ICB and the 10 Trust where appropriate.
Thank you. I think it's important for us to realise that the standing financial instructions are within our control. They're for us to set. That's what we're doing. The way that we operationally manage them, there may be some flexibility around, and that's perfectly legitimate.
Okay, thank you very much. That's really helpful. And Jonathan, thank you for being open with us on the variety of reporting today as well. Grateful to you. Okay, so can we approve the standing financial instructions? Yes, nods around the table. Thank you very much. Item 15 is our conflict of interest policy, which is here for approval. Laura?
Thank you. So the conflicts of interest policy was one of the very first ones that we approved last July. It's an important policy. It forms part of our governance handbook, and we did approve it initially for a year because we knew that things would likely need reflecting on after 12 months of operation. So the policy has been reviewed. It has also been through members of Audit Committee who are happy to recommend it for approval to you today. They are largely minor changes, because we have a number of points of updated guidance. We've had an internal audit review with some recommendations, and we are also preparing for the launch of our new Declarations of Interest portal in the next couple of weeks. So it's here for approval, please. Okay.
Any questions at all about it? No, happy to approve it. Yeah, nods around the table. Thank you very much. And Laura, when Laura says there's going to be a live portal, colleagues, that's then handing the responsibility to you to declare your conflicts of interest on a regular basis, and also means for members of the public we have a live register as well, so we don't have to wait for the next board meeting in public. It's there live online, which I know has been welcome because we've had questions of the public about that, particularly back in our March partnership board meeting. So thank you for finding an effective solution for that as well. Okay, so that's approved. Thank you. Does anyone have any other business before we finish our board meeting in public? No, not at all. Okay. Colleagues, thank you so much. These board days are always long, but hopefully you found them very productive and effective. And again, going all the way back to our discussions this morning on our community services, the engagement session in hearing patient stories and local people's experiences of service, the good and the not so good, and how we can come together as health and care leaders to improve services and offer good quality care. I think it was a really positive start to the day. Thank you again to Rob A and to Becca and to Thea and many others for coming and sharing sharing their experience today and their thoughts and their challenges to us as a board. And thank you to people who've watched online, watch on record, and to members of the public and other colleagues who've come to join us today in person in Batley. So that is the end of our July NHS West Yorkshire Integrated Care Board meeting. Thank you very much.